maybe we could go from the title slide to the second slide, which reads pulmonary hepatic failure in our outline. So what I'd specifically like to cover with you here in the next 30 minutes is to review with you the causes of acute liver failure and how that begets prognosis. In particular, emphasize the importance of recognizing and treating patients with acetaminophen overdose. We'll talk also about N-acetylcysteine for non-acetaminophen acute liver failure. And then really the defining feature that differentiates this syndrome from other patients with cirrhosis who may end up in the ICU, which is the presence of cerebral edema, and how to recognize that, how to monitor it, and how to treat it. And then lastly, we'll talk a little bit about the role of liver transplantation for selected patients. So if we could go to the next slide, third slide, that reads ALF overview. So as many of you know, acute liver failure is an uncommon but dramatic illness defined by the onset of coagulopathy as well as mental status changes in a patient without known liver disease. And the numbers that we put around those parameters are an INR greater than 1.5 and mental status changes that occurred acutely within the last 8 to 26 weeks. So these are patients with severe acute liver injury, but by definition, we're excluding the more common patients who have alcoholic liver disease and alcoholic hepatitis, as well as HBV reactivation and sepsis with intrahepatic cholestasis and DIC in an ICU patient. The key clinical features of acute liver failure are that these patients can rapidly deteriorate on you, having been previously well, and it's not always predictable, largely due to the rapid development of cerebral edema, which occurs in the setting of massive hepatic necrosis. And many of these patients also can develop severe life-threatening infections from the loss of their particular endothelial function. In general, with ICU care, it's predicted 30 to 40% spontaneous survival rate, which obviously means 60 to 70% likelihood of mortality in the absence of emergency liver transplantation, which is available in about 120 centers throughout the United States. And in the patients who get transplanted, it's actually pretty good survival considering how sick they are going into the surgery, with about a 75 to 80% one-year survival these days. So if we could go to the next slide, which should read evidence-based management of acute liver failure. So if we want to know the evidence contour for what we should do, it's pretty limited because there's not been very many randomized controlled trials, largely due to the general low prevalence of this or incidence of this disease state in the general population, anywhere from 2,000 to 3,000 cases annually in the United States. And so therefore, it's been difficult to conduct randomized controlled trials. That being said, there's a couple things that we know should be the bedrock of management, and that would include N-acetylcysteine for acetaminophen overdose, and I'll show you some data for non-acetaminophen patients. An old study indicating that H2 blockers reduced bleeding in patients on the ventilator. CVV-HD was better tolerated than hemodialysis in the patients who had renal failure, and mannitol in one study of 30 patients was better than no therapy for patients with elevated ICP with acute liver failure. We probably know more about what not to do, and there's two modestly sized studies of corticosteroids in non-acetaminophen patients, and they clearly did not have any benefit and, in fact, slightly higher rates of infection. So empiric steroids are not recommended. Enteral decontamination was also tried and didn't work. Charcoal hemoperfusion was done in the 80s through the King's College Group and didn't improve outcomes. And more recently, use of porcine hepatocytes in a dialysis-like cartridge through a bioartificial liver device through extracorporeal circuit. Also did not improve survival. And then there's a study that was published in Annals of Internal Medicine about 2 years ago from a multi-center French group demonstrating that albumin dialysis with the MARS device also did not improve outcomes. So despite the desire to consider using extracorporeal therapies, they really haven't proven efficacious in this space. So now the next slide, I believe, should be my question. Should say at the top, question number 1. And I believe this is the audience response question. So it reads, the leading cause of acute liver failure in the United States is A, acetaminophen overdose, B, ischemic hepatitis, C, idiosyncratic bili, and D, hepatitis B. So if you could hit your clickers, please go ahead. I'm not going to be able to see anyone's response, literally, and I'll give you a few seconds to respond. Perhaps Henry or Joe could summarize those results, and I'll wait 15, 20 seconds here for the audience to look at the data.
Do you want me to say something? Oh, he can't hear us? Okay, well, I mean, we see that 89% got number 1, which is the correct answer, but is Bob going to go ahead then?
Okay, so 89% got the correct answer. That's great. And this is an important point to recognize the leading cause, and that's why we're going to spend some time on the selection A. So if we could go to the next slide, it says etiologic screen for fulminant liver failure. So it's very important early on to identify the cause of acute liver failure. These patients clinically look the same. They're quite ill, and it requires a bit of work on our part to identify what's causing acute liver failure. So since acetaminophen is the most common, we want to look for that in every patient. And you can do that, as you know, by history, but more importantly, by checking serum acetaminophen blood levels and also doing a tox screen. And then you also want to rapidly order your hepatitis serologies, a Hep A IgM, a Hep B surface antigen, and an anti-HB core IgM level as well. Those may take 12 to 24 hours to get back. And then there's other specific diagnoses that you may be considering. So, for example, autoimmune hepatitis, where a patient may have positive ANA, smooth muscle, and gamma globulins. Those are going to require a little bit more time to sort out. Pregnancy-related acute liver failure usually occurs in the 3rd trimester, and you're looking for toxemia and evidence of health and that sort of thing. Herpes and malignancy are pretty uncommon, less than 1%, and those usually require PCR testing for herpes and or CMV, and then for malignancy, you usually need a biopsy to clinch the diagnosis. But again, those are pretty uncommon causes of acute liver failure. Similarly, Wilson's disease, which tends to occur in younger individuals, can use a combination of diagnostic tests. But Chiari, where you lose all of your hepatic venous outflow simultaneously, you can usually pick up initially on ultrasound Doppler and confirm it on cross-sectional imaging. And then in the right clinical setting, someone with massive volume depletion, heat stroke can develop acute liver failure from massive volume depletion. So we could move to the next slide. This is an overview of the causes of adult onset acute liver failure. This is part of a study that I've been involved with the past 20 years. This was a data cut from a few years ago where we had 1,000 cases, and this is where the answer from the original question comes from. You can see there on the far left that acetaminophen by far and away is the most common cause. There are about 500 cases at the time. And then you can see the bars really fall off. Idiosyncratic drugs is next, hepatitis B, hepatitis A, and so on, but they're relatively smaller players compared to acetaminophen. And then on the far right is the indeterminate acute liver failure, which means that we've worked them up for every known cause, and we still don't know what's causing their liver failure. So in addition to the size of the bars, there's some asterisks above those, which is the other y-axis of spontaneous survival with ICU care. And you can see this is why we want to know what's causing the acute liver failure as quickly as possible. Patients with acetaminophen overdose actually have a pretty good spontaneous survival of about 70%. Similarly, patients with hepatitis A do pretty well. Patients with ischemic hepatitis do pretty well. And women with pregnancy-related causes do pretty well with delivery. On the flip side, the patients you really should be worried about are the ones who have idiosyncratic drug toxicity, say from INH, nitrofurantoin, any drug that leads to acute liver failure idiosyncratically can cause, have a poor prognosis. Similarly, Hep B and Wilson's patients and indeterminates. So we generally look at good prognosis and bad prognosis. So next slide stratifies outcomes by the etiology and the maximal coma grade that the patients achieve during their hospital course. And you can see across the board that patients who really get to the point of intubation or complete loss of their neurological exam with a stage 4 coma do poorer than patients who just have a peak coma or encephalopathy grade, I should say, of grade 1 to 2. So some simple things, if you have the diagnosis and the bedside clinical exam, you can get a pretty good sense as to how well your patient's going to do in the short term. So if we move to the next slide, another way of looking at etiology is not just prognosis, but is there anything that you can do about it? So I've listed out some of the disease-specific therapies that we know help. So for someone with acetaminophen overdose, as you know, if you identify them within 12 to 18 hours of acute presentation and ingestion, you can potentially lavage the stomach to remove pill fragments. You can give activated charcoal to reduce further absorption of the acetaminophen. And then, of course, the antidote is N-acetylcysteine. Amanita mushroom toxicity, not very common, but certain parts of the country sees this in times when people are going out picking wild mushrooms. There's an enterohepatically circulated toxin that's mediating the liver damage. So we like to do gastric lavage there. There's some data for IV penicillin, some data for IV silymarin, and also dialysis to remove the toxin. Autoimmune hepatitis should be theoretically treatable with steroids, but our retrospective data indicates that if you get to the point of acute liver failure, many of those patients just simply need a transplant, and the benefit of steroids, even in those patients, is equivocal. If you're thrombophilic and you present with Budd Chiari, certainly we want to get anticoagulation with heparin going quickly. If you have fulminant Hep B, we always try to rescue those patients with the oral antiviral that's safe, but again, efficacy is limited here. Herpes, acyclovir is obviously the drug of choice, but again, many of these patients present with advanced encephalopathy and don't do well. Pregnancy-related causes in general, whether it's fatty liver pregnancy, HELP, toxemia, those are all important, can be treated with urgent emergent delivery / C-section. Next slide is an important slide that, again, goes back to the original question, that without a doubt, acetaminophen is the leading cause of acute liver failure in the United States. This is the data from our study group, but we've been tracking this since 1998, and you can see pretty consistently 40 to 50, 55% of cases on an annual basis are due to acetaminophen. Next slide should read diagnosis of acetaminophen hepatotoxicity. So it's the most common one. We need to know how to diagnose it. So it goes back to the history, but again, we're talking about patients who have an impaired mental status, so this can be very challenging to obtain. You're looking for excessive amounts of acetaminophen intake prior to presentation. Excessive is generally thought to be greater than 6 grams as a single dose. It could be 4 or 5 grams daily over several days, those always can be more difficult with chronic dosing. We know that there's probably some cofactors that may be predisposing some patients. So if you've not been eating, you can deplete your glutathione pretty quickly, and that can predispose you to acetaminophen toxicity. And similarly, if you're drinking alcohol, you can rev up your oxidative metabolism of acetaminophen to the NAPQI, which then predisposes to liver injury. Now, there's about 60,000 cases of acetaminophen overdose a year in the United States, and it's the ones with the high AST and ALT that will go on to acute liver failure. But they aren't really any clinically different than an acute Hep A or acute B or ischemia when they first present. So you obviously have to work them up for other causes as well. And one of the specific tests that we like to look for early on is the serum acetaminophen level, which you can get in most hospitals within an hour. Beware that if someone is jaundiced, many of these assays for acetaminophen are colorimetric, so a jaundiced patient with a bilirubin greater than 10 may have a false positive low-level serum acetaminophen level. But clinically, most patients with acetaminophen overdose have a normal bilirubin. So if the bilirubin is high, unlikely to be the acetaminophen to be the cause of acute liver failure. Next slide is a RUMAC nomogram, where you can plot out the blood level of acetaminophen that you get versus the time of ingestion. And this is the original data that led to the plot. And if you go back and look at that paper, it was over 30 years ago now. They took about 1,000 consecutive cases of acetaminophen overdose, and they gave all of them NAC. And they then said, well, how useful is the blood level of acetaminophen after the time of ingestion in predicting liver toxicity? And it's actually pretty good in that if you're above the line there, you're probably going to get liver toxicity. There's the intermediate range of possible risk, and then little to no risk if you're below it. So it's a very useful algorithm in the first 24 hours of management. And I would remind you that less than 1% of people died, even back in the 80s, if they all got NAC. And those who didn't do well were those who had a delay in NAC or whose ALT was already greater than 1,000 at presentation. So I think that's an important clinical point, that if we give these therapies right away in the ER, et cetera, they can do well. If you could please move to the next slide, it should say N-acetylcysteine at the top. N-acetylcysteine, as you know, has been around for a while. It enhances particularly intrahepatic and total body glutathione stores, which can get rapidly depleted in anyone within 24 to 48 hours with fasting or an acute illness. For acetaminophen overdose, we've been using oral NAC for many years, and you give that orally as initially a load of 140 mg per kg and then 70 mg per kg Q4 hours. But you're going to cause nausea and vomiting that can be significant in 10 to 20% of patients, which you can try to attenuate with Zofran and other antiemetics. So a couple of years ago, Cumberland came up with an IV formulation called IV NAC, or the trade name is acetadote. And they did a study of a 24-hour infusion of acetadote for patients presenting with acetaminophen overdose. And we generally tend to reserve this for patients who have the inability to absorb oral NAC. So obviously if you have a short gut, if you have an ileus, and then in pregnant women, we prefer to give it to get the blood levels high as quickly as possible to try to protect the fetus. We oftentimes will also use it in those patients who you've tried oral NAC and they're just not able to keep it down. The dosing here is different, and it's written out there. Again, it's a loading concept followed by a continuous infusion. And one point of clinical confusion oftentimes comes up is that the package insert only indicates a 24-hour dosing protocol, yet clinically, particularly in these patients who have liver failure, we're going to want to keep going for 72 hours or longer. So you would just continue the 125 mg per kg after day one. You are giving here IV N-acetylcysteine, which is a sulfa drug, so you are going to incur more anaphylactoid type of reactions. with rash, a little bit of bronchospasm, and so on. So these patients clearly need to be in a monitored environment. And in fact, I'd say if a patient has bona fide sulfa allergy, I would not give this IV sulfa drug to them. Next slide is acetaminophen acute liver failure in the United States. This is some data from our study group describing the clinical features and outcomes of patients with acetaminophen overdose who got to acute liver failure. This is over several years, and interestingly, what we found was that roughly half of the cases of patients who get to acute liver failure with a high INR and impaired mental status, that when you look at that subgroup, the sickest of the sick, roughly half of them were non-intentional overdoses compared to the intentional overdoses. So it's quite concerning. In other words, they're taking acetaminophen-based analgesics for some therapeutic intent as opposed to a suicidal gesture. Clinically, they also look a little bit different because they've oftentimes been overdosing over several days. Their ALT tends to be a little bit lower. Their presentation, the total amount of acetaminophen in grams is still quite significant, 34 grams and 29 grams. The blood levels of acetaminophen, as you might expect, tended to be lower because they've overdosed over several days as opposed to a single time point ingestion with most of the intentionals. And interestingly, there's a lot of confusion that leads to this. So many of these patients were taking multiple acetaminophen-containing products and just simply did not know it, and sometimes their physicians didn't know it either. And in particular, we found an overrepresentation of acetaminophen narcotic congeners, and in particular Vicodin, and Vicodin ES was a big player here. So this actually recently led to some regulatory actions from the FDA, as you're probably familiar with, where they reduced the amount of acetaminophen in all prescription narcotic products about a year ago. So we're hopeful that we will see a reduction in these non-intentional cases going forward. Clinically, a similar proportion of patients were listed and underwent transplant, and overall survival was similar between intentional and non-intentional. So let's move on to the next slide. General measures for all acute liver failure patients. So we've talked a lot about acetaminophen, but the patients there in your ICU, what are we going to do? So like other ICU patients, we're looking for trends over time. So serial labs are really important here. Serial LFTs, INR, and factor V is a more sensitive marker of liver recovery than the INR is. So we frequently will use that early on in the first 24 to 48 hours to see if it's going up or going down or plateaued. About 30 to 50% of these patients develop AKI, so you have to watch their kidney function, and then particularly early on and knowing if the patient has lactic acidosis, resuscitating them. And also, ammonia levels are proving to be more and more useful over time, particularly as we're developing ammonia-trapping drugs that we're testing in clinical trials. Don't forget the simple things. These patients, it's their livers that's failing, so they can develop hypoglycemia on top of everything else, and that's easily treatable with glucose supplementation. Common question that comes up is, well, gee, this patient's sick, they're intubated, should you transplant them or not? Why don't you do a liver biopsy? And we don't do that because, number one, it's very risky to do with bleeding. And number two, it has been attempted in the past, and because of sampling artifact, it's really not predictive of outcome. So we don't routinely do liver biopsy for prognosis. Next slide, infections. Infections are a big part of the syndrome here. 80 to 90% of patients will develop an infection somewhere during their hospital course. Tend to be bacterial in most patients, and it can be spontaneous bacteremias across the GI tract from acute portal hypertension and impaired liver function.
We could probably go to the next slide. Okay, good.
Okay.
All right, good. Keep going. We're on infection and patients.
Yeah, infection, right. So we're talking about infection. So bacterial infections are common, typical respiratory, GI, and urinary pathogens. Fungal infections tend to present later at day 3 to 5 with fever, hypotension, and unexplained leukocytosis. So because of the high frequency of infection that can worsen the syndrome, we frequently use preemptive broad-spectrum antibiotics early on. And another key management point is if these patients spike a fever, this can worsen their encephalopathy, so we want to keep their temperature under 100 degrees and oftentimes use cooling blankets. Next slide should be coagulopathy in fulminant liver failure patients. So the coagulopathy here, which is part of the defining element of the syndrome, is usually multifactorial with low platelets, hypoprothrombonemia, and a component of DIC. Interestingly, only about 10% of patients actually develop bleeding, and the bleeding tends to occur in the mucosa of the GI tract. So therefore, we do recommend a PPI, but we don't recommend routine prophylaxis with blood products to prevent bleeding. But we only do that if you're planning to do an invasive procedure. So if you're going to do an invasive procedure, you want to try to get the INR down to under 1.5 and platelets greater than 50. Obviously, give cryo if your fibrinogen is low. And then I think something we'll see in the next few years is the utility of the ROTEM in the medical ICU to better guide blood product utilization. Next slide has a title, a multi-center randomized trial of IV NAC versus placebo. This was a study that we published a couple years ago of using IV NAC for non-acetaminophen acute liver failure patients. It's double-blind, randomized, 173 patients. And the primary outcome, as you can see there, was overall survival at 3 weeks, with our hypothesis that the NAC-treated patients would do better. There was reason to believe, based upon some preliminary data, that NAC may improve not only liver function, but reduce the frequency of multi-organ failure. Next slide is a bar graph, and it shows on the far left, the primary endpoint of the study of overall survival was not significantly different between the NAC-treated patients and the placebo-treated patients. However, transplant-free survival was significantly better in the NAC-treated patients, and this was particularly true in patients who had early-stage encephalopathy. Next slide. So summarizing IV NAC for non-acetaminophen acute liver failure, we didn't improve overall survival, but we certainly improved transplant-free survival, which many of us think is very important. We didn't show a difference in length of stay or number of organ failure events. The NAC was generally well tolerated. And so we suggest you consider this for adults with acute liver failure, but remind you, a word of caution, there was a study also done in children where they looked at 1 year survival as opposed to 3 week survival, and they actually did not see a survival benefit. In fact, the NAC-treated patients had a lower survival and a lower transplant-free survival. So in the pediatric ICU, this would not be recommended. That certainly could be considered in the adult ICU. Next slide, liver transplant evaluation. This is done at the transplant center because we need to know whether we're going to move ahead quickly or not to get this patient an organ. So the quicker you get the patient to the transplant center, who needs it, the better. It's a variety of medical and surgical and psychosocial evals done quickly, blood tests, BBO blood typing, and assessment of their cardiopulmonary function. You can usually do a transplant evaluation in about 12 hours to try to determine if someone is a candidate or not. Next slide. So while you're evaluating them for transplant, you have to go back and manage the patient. And the cerebral edema is the most unique aspect of this syndrome. It's a leading cause of death. It's more likely to occur more rapidly your liver fails and can cause long-term neurological sequelae. Next slide, which is a cartoon of the brain. And the issue here is if we can treat it, any syndrome, if we understand what's driving it. And so the cerebral edema and acute liver failure, the mechanism is not entirely known, but what we believe happens is that when you have a severely necrotic liver, you have release of pro-inflammatory cytokines, and you also have failure to detoxify aminogenic substances. So both ammonia and other ammonia-like substances circulate at high levels, And the astrocyte within the brain parenchyma can take out a mole of ammonia and other ammonia-like products by converting glutamate to glutamine synthase. And that glutamine molecule then gets trapped within the astrocyte and can pull water into the cells. So it's believed to be an osmotic effect into the astrocytes that leads to this syndrome, and across the whole brain, enough tissue swells, you then push your CSF out and you get brain swelling, loss of the sulci, and eventually herniation if it goes unchecked. Later on in the syndrome, we believe there's also some loss of the autoregulation of blood flow into the brain and probably hyperperfusion actually, but that's felt to be a later phenomenon. Next slide. So clinically, the way these patients present is initially they can really fool you. They were bright outpatients who really had no medical problems, and they may just have a slight change in their personality. They're a little more sleepy, maybe a little bit agitated. So we do like these patients to be observed frequently with neuro checks in the ICU. We do not want to give them any kind of sedative, Benadryl, benzodiazepine to help them sleep. In the meanwhile, we're rapidly working behind the scenes to figure out if they're a transplant candidate and what's driving the liver failure. Next slide. Grade 2 patients. These patients tend to be now disoriented, they're becoming drowsy, they may have upper motor neuron signs, hyperreflexia. And here now you have to worry about complications of the cerebral edema. They can certainly have intracranial bleeding spontaneously. If they're getting severely agitated, you may need to control the situation with propofol or midazolam. If they're spiking a fever, having a white count, that could be driving this. You're probably going to be needing to start antibiotics, and also saying, is this patient going to need a transplant sooner than later? Next slide, grade 3. At this point, the patient is incoherent, sleeping, markedly confused, only arousable to vocal stimuli. So here you have to worry about airway protection. You're frequently going to have to intubate them. And then usually the other organs may be failing simultaneously, so you're going to may need pressors, you may need dialysis, and again, is this patient going to be moving towards transplant? Next slide, hemodynamic monitoring. Because of the multi-organ failure nature of these patients, particularly with brain involvement, some sense of central pressures is important, whether it's a CVP or a SWAN, because you don't want to resuscitate these patients because you can make their cerebral edema worse while you're trying to treat their systemic hypotension. If you do need to dialyze them, it's recommended to use CVVH over hemodialysis due to the better tolerability from a hemodynamic perspective. And really, the ICU management now is not so much just directed towards the mean arterial pressure, but it's really the cerebral perfusion pressure in this particular group of patients that we're trying to maintain greater than 60. And we can identify the map very easily. The problem is, what is the ICP when you have someone who's intubated on propofol? Lost your neuro exam and you can't really tell. From the pressors perspective, if you do need to use pressors, there's one study suggesting Levothyroxine would be preferred over vasopressin. And we want to avoid other causes of incidental increases in ICP. So, for example, straining, Valsalva, vigorous suctioning through the ET tube is all known to increase ICP in anyone. Another simple thing that you can do is keep the head of the bed of the patient at least 20 to 30 degrees above the horizontal to avoid excessive venous hypertension in the brain. And then, obviously, the PEEP on the ventilator is another important determinant of ICP, and if you can use the lowest PEEP possible, that is preferred. Next slide, ICP monitoring. So if we're trying to maintain cerebral perfusion pressure, we want to know what the ICP is. So the best way to do that would be to put a monitor in. And that's desirable from an intensivist perspective. But there can be some pushback about, say, show me the data that the patient will live longer, and what about if they bleed into their brain, which can be catastrophic. So that's the concern of putting the ICP monitor in this group of patients. Next slide. This is data on ICP monitoring in grade 3-4 patients from our acute liver failure study group. And this is retrospective analysis. We placed a monitor in 92 patients, and 240 did not have a monitor. And you can see that we tended to monitor slightly younger people. They all had bad INRs. 100% were intubated. Many of them were already on dialysis, and the vast majority were also listed for transplant. So there tended to be a bias towards monitoring patients in whom you're proceeding with a liver transplant. Next slide. This is a graph showing that when you have the monitor in, the intensivist was able to offer more medical therapies in an effort to lower the intracranial pressure. So you can see in the hash bars that the ICP monitored group got more mannitol both on day 1, 2, and 3, was more likely to then have increasing use of barbiturates on days 1, 2, and 3, and also more likely to receive pressors in an attempt to maintain CPP. So having the monitor in retrospectively indicates you can do more interventions. When we then looked at outcomes, survival was the same, but again, we tended to monitor the sicker patients who were going towards a transplant. So that's the data that we have on monitoring. The rate of intracranial bleeding and complications was less than 5%. Next slide. So how do you place a monitor? It's usually done by a neurosurgeon, although around the country, I think more and more neurocritical care intensivists are starting to learn how to place these at the bedside. They're generally going to want a non-contrast head CT to make sure there wasn't spontaneous bleeding already. They're going to want you to address the coagulopathy. And in particular, with the elevated INR, you generally want to start with FFP to try to lower it. Next slide. Recombinant 7A, though, is usually required to really normalize the INR in these patients because they're just not synthesizing enough clotting factors. As you know, recombinant 7A causes clot formation wherever tissue factor is released, which is any surgical bed or any kind of wound. And in one study, it corrected the INR in 100% of patients versus 0% who did not get the recombinant 7A and only got FFP. And in that study, 100% of those patients who got recombinant 7A had an ICP monitor placed versus only 38% who got FFP alone. Because this causes clot formation, you need to be careful and should not give it to patients who have blood GRE cancer, DVTs, and so on. Again, you have to give the FFP first because you have to replace all of the low levels of clotting factors. And then the suggested dosing is 80 micrograms per kilo over 5 minutes, and it basically creates a 4 to 6 hour window for you to do your procedure, whether it's placement of the monitor or other invasive procedure. I would just remind you that this is not currently FDA approved for this use. This is expert opinion, and it does cost approximately $5,000 per dose. Next slide, treatment of cerebral edema. So you have a monitor in. When do you intervene? And your goal, again, here is to maintain the CPP that shouldn't be less than 50. We want to maintain it greater than 50, but if it drops to less than 50 or the ICP goes up, that's when you're going to want to intervene. Most of these patients will already be spontaneously hyperventilating themselves. If not, you can adjust the ventilator. And then the first step for a spike in ICP would be to give IV mannitol, but there's some limitations there with the osmolarity and osmolar gap. More and more in our center, and I think in other centers, we're drawing from the head trauma literature and using hypertonic saline more and more in our ICU for these patients, although there's no head-to-head study. For patients who fail osmotic agents, then pentobarbital can be used, but again, this is tricky to administer because you can cause systemic hypotension, which will worsen cerebral perfusion, and also the drug tends to accumulate, so you have to check levels frequently and to avoid overdosing. Next slide. Refractory cerebral edema, despite your best efforts with pentobarb and osmotic agents, some patients may progress. There's limited data on hypothermia. There was initial data from King's College about 10 years ago indicating they were able to successfully treat refractory patients with cooling blankets, get them through transplant. We recently published our data last year on hypothermia use in the United States in acute liver failure. We had 97 patients who got therapeutic hypothermia given predominantly through cooling blankets and 1,100 controls. And it was purely a retrospective look. And what we saw from that retrospective analysis, the rate of infection, bleeding, and overall survival was similar. So we don't, there's no obvious signal here of worse outcomes, but we clearly need to do a randomized controlled trial. There's other clinical issues here, for example, how to prevent shivering, how quickly to rewarm the patient, so on and so forth. Next slide, King's College criteria. These have been around for quite some time to try to help identify who is not going to survive. And as you know, they're broken down by acetaminophen and non-acetaminophen groups. Next slide. Patients with grade 4, again, these are the critically ill ones who have a poor chance of spontaneous recovery. And sometimes they may just continue to progress despite what you're doing or even waiting for a liver transplant. And certainly some may progress to cerebral herniation, and you may need to do a technetium blood flow scan to determine the absence of blood flow. That's irreversible, and you would not want to proceed with the transplant. Other patients who get refractory hypotension, multi-organ failure, severe hypoxia, where we were initially planning to transplant. And I'd say it's probably about 10 to 20% who develop contraindications while they're waiting for an organ that precludes them from a subsequent transplant. Next slide, we're coming down the home stretch here. So what about liver transplantation? Well, again, I think it's important to know where your closest transplant center is, wherever you work, or maybe even if you work in the transplant center. And the quicker you get the patients with the poor prognosis to the transplant center, I think the better in terms of sorting them out. If they are a suitable candidate, they can leapfrog all the chronic patients. It's what's called a status 1, where they go right over all the chronics. And in addition to going to the top of the list in their blood group, most regions will share organs across state lines to try to get these patients transplanted in a timely manner, so you can draw from 2 or 3 states. Most centers will take an ABO compatible as opposed to identical, depending upon the clinical circumstance to get the patient transplanted quickly. Currently in the U.S., it's anywhere from 2 to 3 days, though, to find a suitable organ for adults. And on an annual basis of the 6,500 liver transplants done, about 200 are done for fulminant liver failure. So it's a small group, but an important group. And as I mentioned before, the ones who you do transplant despite their critical illness actually do pretty well at 1 year. So final slide, acute liver failure in 2015. To summarize key clinical points, this is uncommon, 1 in 3,000. 3,000 cases a year annually, but it's a dramatic illness that you need to be aware of. Making a diagnosis quickly is important because you can initiate disease-specific therapy and, more importantly, have a sense of the prognosis of your patient. I would suggest you consider giving NAC to anyone who could have acetaminophen overdose, and also for patients with non-acetaminophen overdose, at least adults, there may be some benefit, particularly if they're early stage encephalopathy. The cerebral edema and sepsis are important ICU issues to be aware of in these patients. We talked a lot about the monitoring and use of antibiotics. And then, obviously, again, transplant plays an important role, but is not necessarily a guarantee. Let me stop